All right, on this episode, I figured I'd switch it up a little bit and talk about something non-ECG related. So we're going to go over how to interpret an arterial blood gas. And this is probably going to end up being a three-part video where I go a little bit more in depth with acid base and then do some advanced ABG interpretation, talking about like how to calculate compensation and stuff. So for this episode, we're going to focus on just what's on an ABG, what it represents, and then how to interpret them. Right, so the ABG kind of tells us two big chunks of information. It gives us a very accurate assessment of the patient's acid base, uh, plus the compensation mechanisms involved. So it'll tell us what the actual pH of our patient is, and then what our compensation mechanisms are doing to either help, or if they're the causative element, or if they're both causing the acid or alkalotic state. And then the other chunk is going to be the oxygenation of the patient. So it'll give you direct sampling of the arterial blood to tell us the exact oxygen content in a very precise manner. So the first major thing that we're looking at when we look at an arterial blood gas is the pH. And like I said, I'll probably do another video going over just acid and base in general, because I know that's a kind of a dry topic that most people kind of skim over. And then as you get into emergency medicine, you really start to kind of need to understand this, since acidosis is a primary problem that we encounter quite a bit in emergency medicine. So the pH, in very short, abbreviated terms, is just it's a measurement of the amount of hydrogen ions in a system. That's what the H in pH stands for. It's an inverted ratio, so it's a little bit backwards from what people expect. But the more hydrogen you have in the system, the lower the pH and the more acidic you are. The less hydrogen you have, the higher the pH and the more alkaline or base you have. And it's pretty that simple. Now, neutral on a pH scale is 7. Human blood exists in a slightly alkaline state, and so our normal pH for human plasma is 7.35 to 7.45. So we exist slightly alkaline, off neutral. And yeah, I've heard a couple theories about that. One that resonated with me is just it was an evolutionary adaptation, since when we get sick, we tend to become acidic over alkalotic, and so we get a little bit of a buffer, and we tend to tolerate a drop in our pH a little bit better than a rise in our pH. Now, just like every other mechanism in the body, we have built-in compensatory mechanisms to try to regulate and maintain homeostasis. And there are three big chunks to our compensatory mechanisms. The first line of defense is our chemical buffer system. We actually have three. The one we hear about the most is the bicarbonate buffer system, which is driven by carbon dioxide and the various states that it can exist within the body. And that can be as legitimate run-of-the-mill carbon dioxide, or it can be converted into carbonic acid via carbonic anhydrase. And they can also dissociate into its conjugate base bicarb. And so it can kind of shift states. And in a homeostatic balance, there's typically 20 bicarbonate anions compared to one carbonic acid. That's kind of the ratio to maintain homeostasis. And so we have an acid and a base existing in our blood, and that's kind of the definition of a buffer system. And it operates, the analogy I use is like shock absorbers on a car. If you feel a little bump in the roadway, the shock absorbers will absorb that, so you have a nice smooth ride. Um, and that's kind of what a buffer system does, is if you ingest or produce a small amount of acid or base as we're going to do on a daily basis, the buffer system kind of buffers it out. It keeps it even and maintains a normal neutral pH of 7.35 to 7.45. Going back to my shock absorber analogy, you hit a big enough speed bump, though, you hit a big enough pothole, you feel that. And the same thing here. If you have a big enough disturbance in your pH, the buffer system will not be able to handle it. And then you're going to start getting deviations in your pH, which will cause your other compensatory mechanisms to kick in, whether that be the respiratory or renal system. And oftentimes one of those one of our compensatory mechanisms fails. A good example being your respiratory system tries to manage through carbon dioxide levels. And if you get sick and you get sick lungs and they no longer allow good gas exchange, well, that's going to cause a disturbance that will inhibit it from being able to manage or mitigate any sort of CO2 issues. And so kind of moving through the different items on an ABG. We talked about pH. The next one down is your PaCO2. It's just an acronym, stands for partial pressure of arterial carbon dioxide. This is an arterial sample, so this is a direct measurement of freely dissolved carbon dioxide within the blood. It is a direct marker of the respiratory system because our lungs are able to mitigate our CO2 levels through changes in the depth and rate of our breathing. Our normal levels are 35 to 45 millimeters of mercury. And CO2 in the body is converted readily into carbonic acid. So the more CO2 I have, the more acid I have. So if my PaCO2 is higher than 45, then that's producing more carbonic acid, and that's considered generating an acid state in the body. If my PaCO2 is less than 35, then I have less acid, and the opposite, or the same thing as saying less acid is saying alkaline or base. So if I'm missing an acid, then that's the same thing as saying a base. So if so CO2 kind of always throws people off because it goes the opposite of what you would want it to do, because as my CO2 goes up, my pH goes down, and as my CO2 goes down, my pH goes up. So they're inversely proportional to each other. So that's always the one that kind of throws people when we're looking at an ABG, is just kind of remembering that CO2 is an acid. That's the best way to look at it. And so as it goes up, your pH is going to go down. And then one other little side note here, because we talk a lot about, in emergency medicine, we use end-tidal CO2 quite a bit as an analog to PaCO2. And in certain respects, it is a pretty darn good analog to an arterial CO2, but just as a reminder, it's not a true analog. Your end-tidal CO2 is dependent on a couple of variables in order for it to be accurate. And so you have to have good pulmonary blood flow. And we see that when we measure CO2 in cardiac arrest, right? Our carbon dioxide levels, when we measure it, when we sample it through the end-tidal CO2 monitoring, is low in cardiac arrest. But if you were to do an arterial blood gas on a patient in cardiac arrest, the CO2 would often be high because the CO2 is not able to diffuse across the alveolar membrane because it's not perfusing those alveolar membranes appropriately. And so you're only getting a small portion that's actually able to diffuse across and then be exhaled to be sampled by the end-tidal CO2, right? And then anybody in emergency medicine knows if you are monitoring CO2 in a cardiac arrest and all of a sudden it jumps up really high, that can be a predictor that you got return of spontaneous circulation, because now the lung parenchyma are being saturated by blood, and that CO2 is now able to diffuse across and be sampled. You can also see this if you have poor ventilation. So if you have really tight bronchospastic lungs where you're not getting to read end alveolar gas, you will get a false low reading, even though the patient's arterial carbon dioxide level is actually quite high. You may actually not be able to sample that, especially if you're using like a non-invasive sampling device. So there's just a couple caveats. The end-tidal CO2 can often be lower than the patient's actual arterial carbon dioxide. The opposite cannot happen. So you cannot have a higher end-tidal CO2 than a higher PaCO2 if you're getting, unless it's some sort of like mechanical issue or something. HCO3 is just the chemical formula of bicarbonate. This is controlled by your kidneys. Your kidneys can acidify or alkalinize your urine, so they can control the amount of bicarb and hydrogen ions that are being reabsorbed by the body and what are being eliminated in our urine. And that is a direct mechanism upon which we can buffer. It's actually a little bit more effective than your respiratory system. However, it takes a little bit longer. So your respiratory system can kick in very quickly. But your kidneys can do a better job at actually managing this system. Normal values are 22 to 26 milliequivalents, so that's the unit of measurement we're using for that. And then the bicarb's a little bit easier to remember when we're looking at ABGs, because since it's a base or it's alkaline, as the bicarb goes up, your pH goes up, and as the bicarb goes down, your pH goes down. So they're directly proportional, unlike CO2, which was the opposite. So if my bicarb comes back at 28, well, that's a base, or that's alkaline. If my bicarb would come back at 20, that's an acid. Base excess, I'm not going to spend too much time on this. When we're talking about basic ABG interpretation, to be honest, you could interpret it without using it at all. It's just a calculated parameter to control for certain variables on the ABG to tell the provider an actual legitimate excess or deficit of base and how much acid or base it would take to restore a pH back to normal of 7.4. So normal is plus or minus 2. So most ABGs reference base excess so that it means exactly as it sounds. If I have a positive 2 base excess, that's saying that I have 2 extra millimoles of base, and it will require the opposite in acid to restore to normal. If I have a base excess of negative 2, that's the same thing as saying a base deficit of 2. And so again, it's something you can use when you're trying to calculate bicarbonate replacement and some other things when we get a little bit more into the advanced interpretation of like your acid base of a patient, but in general, it's not necessary for ABG interpretation. Now, moving away from acid base and shifting to oxygenation, there's 2 parameters on your ABG that help with that. The first one is your PaO2, that's the partial pressure of arterial oxygen. This represents freely dissolved, unbound oxygen within the blood. It's measured in millimeters of mercury. It is a pressure, so it's not a saturation, which is what we classically use non-invasively to measure oxygenation of a patient, which is a little bit misleading. I know we use it quite a bit. Pretty much every patient that is in emergency medicine is going to get a pulse oximeter placed on them, but that isn't a direct correlation to the oxygenation of the patient. I'll give you an example. Since it's a saturation of hemoglobin, its accuracy as a reference or an analog to the oxygenation within the blood is predicated on the amount of red blood cells and hemoglobin within the patient. Someone who's suffering severe anemia will need a significantly less amount of oxygen in the blood to achieve a saturation of 100% because there's fewer receptors for oxygen to bind to. And so, to make it very simple, if I reduced it all the way down and you had 1 red blood cell circulating through your whole body, it would only take, or let's say 1 hemoglobin protein circulating through your body, it would only take 4 oxygen molecules to saturate that. You'd have 100% saturation, but your blood oxygen content and the carrying capacity of that would be markedly reduced. So PaO2 controls for that. It eliminates the amount of red blood cells as a factor, and it just tells you how much oxygen is present. Now you need both because what we really want to know is how much oxygen is being delivered to the tissues, and most of it is bound to hemoglobin. So your hemoglobin count is an important tool as well to determine the overall oxygen carrying capabilities and the oxygen delivery to the tissues. But when I really want to know just how much oxygen do I have in the blood, I really want to look at PaO2. It is a controlled marker that eliminates any other variables, so I know. And again, it's measured as a pressure, so it can exceed 100 and it can be lower. So less than 60 typically indicates pretty significant hypoxemia, and anything over 100 would be diagnosed as hyperoxia. So then SaO2 is your saturation of arterial oxygen. Again, so this is actually telling you how much oxygen is bound to hemoglobin within the arterial blood. Your normal parameters are the same as they are for a pulse oximeter, 94 to 99. And again, one little caveat when you're charting and when you're speaking to other professionals in this, oftentimes I see people kind of mismatch between SpO2 and SaO2. SaO2 is an arterial saturation of oxygen. SpO2 is indicating that the saturation sample was taken from a probe or peripheral sample. So when you're using a pulse oximeter, it's SpO2. If you're doing an arterial blood gas, it's SaO2. All right, so let's do some practice, and I have a chart there to kind of help you use as a reference. So again, I'm just going to kind of run through these. You can pause as you want, so you can practice along with me. So our first ABG we're looking at, I split it into 2 groups. I've got the acid base up top, and then I have the oxygenation below it. So when I'm looking at the pH here, it's 7.0, the PaCO2 is 22, and the bicarb is 10. So when you're interpreting an ABG, and I'm looking to determine any acid-base disturbances, the first thing you want to look at is your pH, and you want to ask yourself, is it an acid, is it a base, or is it normal? So if it's normal, it would be between 7.35 to 7.45. If it's below that, it's an acid. And if it's above that, it's a base or alkaline. once you determine that, in this case it's 7.0, so it's less than 7.35. So that makes it an acid, a pretty significant acid. The next thing that I want to ask is I want to figure out what's the cause. Is it my respiratory system that's the problem, or is it metabolic system that's causing the problem? If it's a respiratory system, then the PaCO2 is going to match with the acid base with the pH disturbance. So what I mean by that is if I have an acidosis on my pH, if my pH is showing acidosis, then when I look, if it's a respiratory problem, then my PaCO2 will also be producing an acid, meaning that my CO2 would be high, right? Because CO2 is converted into carbonic acid, and so CO2 is an acid. And that's not what we see here. Instead, we see our CO2 is low. And since CO2 is low, that would be the same as saying that it's alkaline or a base. And so that can't be the cause in this case. So we go down to our bicarb and we look at our bicarb. Our bicarb is a base, so the more of it that I have, the higher it is, the more base I'm contributing, right? And so normal values are 22 to 26. So if it's above 26, then it would be alkalotic or a base. And if it's low, then it would be an acid. And so we can see here, it's significantly lower than normal. Normal low end would be 22, and instead we see 10. And so this is an acid. And so this matches the pH disturbance. So in this case, we've now decided that we have an acidosis and we figured out our cause, which is that it is a metabolic acidosis, meaning something in our metabolic system is producing an acid. And in this case, it's actually kind of neutralizing a lot of the bicarbonate in the system. And then the last part, when we're looking at the acid base with an ABG, is to determine if there's any compensatory mechanisms at play. Now, first off, this only is applicable if the patient's spontaneously breathing. If you have paralyzed the patient and put them on a vent and you're controlling CO2, then you could understand this and could make manipulations to help compensate, but you could also be making it worse or altering it because you're taking away the body's natural mechanisms. So again, when we're reading these ABGs, we're just going to assume that the patient's spontaneously breathing on their own and that there's nothing amok here. So when I look at the CO2, I go back to that one. That's the only other mechanism left, and I want to see, I ask myself, is it contributing to the acid in the system? Is it doing nothing, or is it trying to help? And since it's a base and our pH disturbance is an acid, I know that the respiratory system is trying to help. This is respiratory compensation. And so anytime you have compensation, you ask one last question, which is it fully compensated or is it partial? To be fully compensated, the pH would have to have been returned to normal. And since we can see that it clearly has not, it's significantly lower than that, then it is only partially compensated. So if we advance the slide here, we'll have our complete answer and interpretation. So like I said, our pH at 7.0 is an acid. Our bicarb is also an acid, so we know our problem is metabolic. And then the last part we always look at is, do we have compensation? Which in this case we do, because the PaCO2 is alkalotic or a base, and so it's trying to raise the pH back up to normal. Now, how to fit this in with a patient? This ABG would fit any of our metabolic acidosis patients. This would be your diabetic ketoacidosis. This could be a septic patient. This could be a toxic ingestion like salicylate toxicity, ethylene glycol, toxic alcohols. This could be a renal failure patient with like uremic acidosis, or a liver failure patient producing some endogenous metabolic acids, and that has an intact respiratory drive. So this patient would be on physical exam. This patient would be, let's say it's a DKA patient. He would be breathing quickly and deeply, maybe that Kussmaul type respiratory pattern, trying to blow off carbon dioxide to stabilize the pH until the body, or until external medicine could somehow correct the issue. In this case, it would be to provide insulin and reverse the pathological ketosis that's occurring, in which case that would remove the ketones, which are acidic, and hopefully that would allow for normal bicarbonate levels to be restored, and then the carbon dioxide level could then return to normal as the pH normalizes. All right, our next one, and again, you can pause and take a look at it, but I'm going to continue on. So we use our methodical approach here. We look at the pH first and we ask ourselves, is it acid, base, or normal? We see a pH of 7.1, so we know it's an acid because it's lower than 7.35. So we have an acidosis. That's going to be part of our formal interpretation. The next step is to figure out the cause. And so we look down at our carbon dioxide and we ask ourselves, is it an acid, is it a base, or is it normal? When we look at it, our CO2 is well above normal. Normal is 45. Remember, CO2 is an acid, and so the more of it I have, then the more acid I have. So since I have an excess of acid, that would be contributing to the acidosis that we see on our pH. And so we know that our respiratory system is a contributor. We look down at our bicarb, we ask the same question, is it an acid, is it a base, or is it normal? And in this case, we have excess bicarb. Bicarb is a base. The more of it I have, the more base I have. And so the bicarb is going in the opposite direction from a pH standpoint. So when I circle back up, I have an acidosis. My CO2 is the contributor, which represents the respiratory system, and then my bicarb, which represents the metabolic system, is offsetting that or attempting to offset that. And remember, anytime we have potential compensation, we have to ask, is it partial or fully compensated? And since our pH has not been returned to normal, this would be partial compensation. So let's see our formal interpretation. So our pH, like I said, is an acid. Our CO2 matches, so this is respiratory acidosis. We look down at the other mechanism. It is going in the opposite direction. It's producing a base or an alkaline system. And so we have respiratory acidosis with partial metabolic compensation. This would fit the ABG of a patient like a COPD exacerbation, someone who has been sick for a little while and has allowed their carbon dioxide level to creep up and produce an acidosis, and the body over the duration of the exacerbation has had time to start retaining bicarbonate as a way to try to restore normal pH to the patient. All right, our next one here. We look at our pH. pH is coming back at 7.54, so this is high. So this is the opposite of the other two. This is an alkaline or basic environment. So we know we have an alkalosis as our acid-base disturbance. We look down at our two systems. Our carbon dioxide level is low. We ask ourselves, is that an acid, a base, or normal? Since CO2 is an acid and there is an absence of it, whereas a deficit of it, where it's low, then the same saying a low acid is the same thing as saying that you have a base. So our carbon dioxide is contributing to the alkalosis in this case. So we have a respiratory contribution. We look down at our bicarb, ask the same question, is it an acid, a base, or normal? In this case, our bicarb falls within normal limits, and so this is a normal bicarb. And so let's see what our formal interpretation is. So as I said, our pH is alkaline, it's a base, so it's an alkalosis. Our carbon dioxide matches, it's also an alkalosis. And our bicarb is doing nothing. There is a normal bicarb. So formally, we know we have an alkalosis that is being caused by the respiratory system. So this is respiratory alkalosis. And because our metabolic system is doing nothing, from an acid-base standpoint, because it's normal, it's not contributing, it's not helping, it's not making it worse, it's not doing anything, we would term that no compensation or without compensation. So this is respiratory alkalosis standalone. This would fit a anxiety attack or some sort of hyperventilation syndrome that is acute and not giving the kidneys time to try and help restore normal pH. All right, our next one, we look at this. We have a pH of 7.57, a PaCO2 of 42, which is normal, a bicarb of 38. And so we look at our pH first and we say, is this acid, base, or normal? That is a base or alkaline. Our CO2 I already labeled for you. I'm not sure why I accidentally did that, but our CO2 is normal. So it's not helping, it's not hurting, it's not contributing. And then our bicarb is high. Normal is 26, so we're well above there. So that's also a base. So let's advance and see what our interpretation is. So our pH is 7.57, so again, that's an alkaline. Our CO2 is doing nothing, and our bicarb is also matching the pH disturbance. So we know our bicarb is the cause, and that's representative of the metabolic system. So we would turn this metabolic alkalosis without compensation. This could be a couple of things. This could be profound vomiting, is probably your most likely, where the patient's vomiting up a bunch of stomach acid, causing a metabolic alkalosis. All right, our next one. We have a pH of 7.14. We have a CO2 of 72 and a bicarb of 25. So when we look at this, my pH, we ask, is it an acid, base, or normal? It is low, normal 7.35. So we have an acidosis as our pH disturbance. We look down at our first mechanism, which is the respiratory system. We look at our CO2, it's high. CO2 is an acid, so we have an excess of CO2, so we have a respiratory acidosis as part of our component. We look down at our bicarb, we ask the same question. We say, is it acid, base, or normal? Falls within the normal range, so it's not helping, it's not hurting, it's doing nothing. So let's see what our interpretation would be on this one. So our pH is an acid, our CO2 is an acid. So this is respiratory acidosis without compensation. This would match like an opiate overdose, where you have acute respiratory failure without giving the kidneys time to help kind of compensate there. Okay, well, we've got our first pH in the sixes, so this is critically low. Any pH below 7 should definitely garner your attention immediately, because we're in dire straits and in need to make some corrective action, especially depending on the disease pathology. So our pH is 6.87, that's well below normal, and so a low pH equals an acid. So we have an acidosis as our primary pH disturbance. We look at our respiratory system represented by our carbon dioxide. It's high. CO2 is an acid. We have too much CO2, so we have too much acid. So we have respiratory contributing. We look down to our bicarb, ask the same question. Is it an acid? Is it a base? Is it a normal? And we are missing bicarb. And since bicarb is a base and we are missing it, that's the same thing as having an acid. So in this case, both the respiratory component and the metabolic component are both causing, contributing to the acidosis that we see on the pH. And so if we look at our interpretation here, our pH is low, it's an acid, our respiratory system is producing an acid, and our metabolic system is producing an acid. So this is mixed or combined acidosis. Both systems are failing here. This could be quite a few things. You see this a lot with like a post-cardiac arrest patient, where they were both malperfusing and then also were not ventilating well, and so it allowed for their CO2 to climb, and they were producing probably lactic acidosis from profound inadequate tissue perfusion, and you just end up with this mixed acidosis state. Could be also be a sick pneumonia sepsis patient where they're concomitantly producing lactic acid from their infection and stress response, and then also having poor ventilation and an inability to off-gas carbon dioxide. Okay, so they've all been really easy now. Now it actually gets a little complicated. So this is the hardest ABG there is to interpret because there's an extra step. So when we look at the pH, we should see a problem because every other one you've seen so far, the pH has been out of whack, right? It has been below 7.35 or above 7.45. And so we see our first pH that falls within the normal range, which maybe it's just a normal ABG, but then we look down and we see both our CO2 and our bicarb are not. And so this is going to require an extra step. So anytime you see a normal pH and your CO2 and bicarb are both abnormal, you have to add an extra step to your interpretation because this is most likely some form of fully compensated acid-base disturbance. And so when your compensatory mechanisms are successful, they only compensate up until the pH returns to normal. So they wouldn't overcompensate. And again, remember, this can't be a patient that is paralyzed and mechanically ventilated where you're controlling their carbon dioxide level, because then, of course, humans can do all kinds of crazy things, and that's not an accurate marker. So this is assuming the patient's respiratory drive is intact and unencumbered by neuromuscular blockers. And so when you see a normal pH with CO2s and bicarbs that are outside normal, you have to add one extra step. So you look at that pH again and you ask, is it closer to being an acid or closer to being a base or alkaline? And so since 7.34 or a low pH would be an acid, you can see that the pH is closer to being an acid than it is being an alkaline. And that's gonna be important. So you're gonna label that as normal, but that it's also an acidosis. And it's, again, not an acidosis because pH normalized, but the pH disturbance that we're going to identify is going to have been an acidosis that the body compensated for. So you look at the pH, you see it's normal, you say, is it closer to being an acid or being a base? And in this case, it's closer to being an acid. And then we repeat the same steps we've been doing for the last several examples. We look down at our carbon dioxide and we go, is it an acid? Is it a base? Or is it normal? So we look at that, CO2 is high, that's an acid, right? CO2 is an acid, there's too much of it, so we have respiratory acidosis. So that's definitely contributing to the acid-base disturbance. We look down at the bicarb, to our metabolic system, we see that it's high, bicarb's a base, we have too much of it, and so we have an alkaline or base for our metabolic system. So we go back up to that pH again, remember, it was closer to being an acid. So the causative problem is the respiratory system. So we have respiratory acidosis that has been fully compensated by our bicarb. Let's advance the slide. Check our answer, and that's what we see. We have a pH that's normal, but it's closer to being an acid. The only one that matches is the carbon dioxide, which is also an acid. So our primary problem has to be respiratory acidosis, and our metabolic system was just able to fully compensate. This would be the ABG of a COPDer who's not an exacerbation. This is just them walking around normal. This is that classic COPD patient that's walking around the house with 47 feet of oxygen tubing and their little portable oxygen cylinder just hanging out, not in exacerbation. This is what they're, if you just broke into their house and just took a random ABG sample, this is what you would see, because they exist in a hypercarbic state all the time. And their body adapts to that by just elevating their bicarbonate levels. All right, and so we have another example. We got another of these tough ones. So we've got a pH of 7.44, so that's a normal pH, but we glance down at our CO2 and our bicarb and we see that they're out of whack. So we got to do that extra step. This is another full compensation problem. So we look at the pH, we say, yeah, it's normal. Which one's it closer to? We realize it's closer to being a base. We look down at our CO2. Our CO2 is low. And so CO2 represents the respiratory system, CO2 is an acid, and we're missing an acid, so the CO2 is an alkaline or basic state. The metabolic system is low as well. The bicarb is low, bicarb's a base, and we're missing it, so that's the same as saying you have an acid. And so let's advance the slide and see what we got. So again, we look at our pH. It is normal, but it's closer to being a base. Look down at our CO2. Our CO2 is also a base, so that has to be the primary problem. And then our bicarb or our metabolic system is the opposite, is going in the opposite direction, or is an acid. So this is respiratory alkalosis with full metabolic compensation. This would match a third trimester pregnant patient. As their blood volume goes up, their minute ventilation increases, they breathe quicker and more deeply, and that blows off carbon dioxide as a secondary byproduct. That's an unwanted effect. That's not that heavy breathing in pregnancy is not a compensation for any sort of acid-base disturbance, and so the body compensates by losing bicarbonate and acidifying the blood through the metabolic system until you get a fully compensated respiratory alkalosis. something to keep in mind if you do have to manage a third trimester pregnant patient on a ventilator. Their normal pH balance is going to be a little bit different than a standard anatomically normal adult human.